Good morning, everyone. I'm Hartford Healthcare's Tina Verona. Well, as you know, October is Breast Cancer Awareness Month, and that was all about today, a topic today here at the Health and Wellness Lounge at West Farms Mall. It was a topic of discussion given by Dr. Niamey Wilson. She's Director of Breast Surgery, Research and Quality for the Hartford Healthcare Cancer Institute. Good morning, and thank you for joining us.
Good morning. Thank you for having me.
Yeah, now you just wrapped up a talk here all about breast cancer, all about surgery. I mean, from soup to nuts, everything. Can you kind of just give an overview to our audience, kind of a synopsis of what you talked about this morning?
Sure. So today's talk was about breast cancer awareness, and October obviously is not the only month that we focus on breast cancer. It can happen anytime. So what we did today was we reviewed some very brief essentials in terms of numbers, how common breast cancer is, and then how to diagnose it, the importance of mammograms, the importance of self-checks, bringing anything that you're concerned with to your provider, and then very briefly kind of went over some principles of treatment, and then left the floor open for questions, and we had a lot of wonderful questions from the audience.
Yeah, really great questions. What's kind of the message that you want to get out there? And I know it's important, obviously, to talk about breast cancer year-round, but specifically during this month, what do you want women to know, and men too?
Sure. Yeah, it can happen in men, so that is something that we should, not forget. My main message for, in general, is just that breast cancer is so treatable. There's always options, there's always choices, and there's always something we can do. And so, not to forget your mammogram and not to be afraid to go in for your testing because you're worried that you might find something. Because if you do go, on a regular basis and get your mammograms done, in general, we can find if you do have a cancer, if it's very small, it's usually extremely treatable. You might not need the big guns, and we can cure it. So my message is really that, to continue getting your mammograms, go to your doctor, don't skip out on your self-exams, things like that.
And breast cancer treatment has certainly come a long way in terms of diagnosis and treatment options. Let's talk a little bit about that.
Yes, in general, I would say that breast cancer has become more and more treatable over time. Breast cancer is very common, right? We see it all over the place. It's here in Connecticut, it's 13.7% roughly. So that's a lot. That's 1 in 8 women. But it's extremely treatable, and the actual risk of dying from breast cancer is very low. It's only 2.5%. And so that's thanks in large part to the research that's being done in breast cancer. And so we're able to offer less invasive surgeries, in some cases even kind of not doing surgeries that we used to be doing 20, 30 years ago. We can lower the rates of chemotherapy that are being administered. As I was mentioning during my talk, there are big studies out there now showing that somewhere between 60 and 70% of women with breast cancer are not going to need chemotherapy. And that's a huge change from what we were doing, 50 years ago, 30, 40, 50 years ago.
And in some cases, it's about taking a pill.
Yes, oh, absolutely. Many cancers, breast cancers, are estrogen driven, and so there are therapies that we have that can that are in the form of a pill, which reduce the risk of breast cancer returning or coming up at all. Because they're estrogen driven, these are pills that help block the estrogen receptors and lower the amount of estrogen circulating.
You are the Director of Research and Quality at the Hartford Healthcare Cancer Institute. Let's talk a little bit about some of the research when it comes to breast cancer.
Absolutely. So we are thrilled to have partnered with Memorial Sloan Kettering. As you know, they are a huge cancer center in New York City, and by partnering with them, what we have done is essentially allowed access to the amazing trials and research that's being done there, bringing it here to Connecticut to our patients here. So we have access to clinical trials. We have coordination with conferences that are being done. We are standardizing our care in relation to how they're delivering their care. So it's been an amazing partnership so far.
I want to look at this model because I think this is fascinating and interesting and something that many women may not realize, that this is the inside of a breast. There's a lot going on in here. Yeah. Can you kind of take us through this?
Absolutely. So this is a model that I have in my office, and it's just, I think it's so helpful because I'll take this off for a second here. So what you can see on the outside, this is what most women are familiar with, right? All they see is the outside. What I know is what's on the inside. And so I understand how to take care of the various things that can go on inside the tissue. So just to orient everybody, this is obviously the skin, this is the nipple. Behind the breast is the pectoralis muscle. This is the chest wall muscle. Then all this yellow stuff around the outside is fat. The pink stuff is supposed to represent breast tissue, milk glands, okay? And then all of these other little findings in here are supposed to represent things that can occur. So fluid-filled pockets, we see those a lot. Those are called cysts. Usually they're nothing to worry about. Sometimes they can have some growths on the inside of them, and so we do, get worried about those.
Can they turn cancerous?
In general, no. We do follow them. If they're seen on ultrasound, we'll kind of monitor them over time. But usually cysts do not ever become anything worrisome. They're sort of in continuity with the milk duct and just a little expansion of fluid there. This is, I think, supposed to represent a benign lump, like a fibroadenoma. Those are also not cancerous. They don't become cancer. They can grow and they can be painful, so sometimes we remove them. But if they're stable over time, we usually just leave them alone, okay? These are other small cysts that are in there. And these are supposed to represent cancers. So externally, you can see there's a little bit of dimpling of the skin there, because as breast cancers grow, they kind of pull the tissue in. And so they can pull in the skin and cause skin retraction. And so that's why we tell patients to monitor their own exam. And if they see any sort of skin pulling in like that, you've got to, get that checked out. There's other types of breast cancer that can grow and sort of push the tissue out. And so those present as a lump that can stick out, kind of pushing the skin out a little bit.
And that's what you hear most common, but you don't hear about the dimpling, which I think is very interesting.
Yeah. So we see both. And this also represents, obviously, a tumor that's kind of really grown and is now kind of invading into the chest wall. That is rare. So.
Now, when you talk about dimpling versus the lump, is any one more advanced over the next? If you see this, is it less advanced than a lump, or?
It's different. I would say that if it is pulling the skin in, then we worry sometimes that it's actually growing into the skin, and so that can be a little more aggressive. But then tumors that grow really big to the point where you can feel them, those are a lot of times patients who are skipping getting their mammograms, because by the time you can feel a lump with your hand, a mammogram could have detected that anywhere from 1 to 4 years ago.
And they grow at different paces, right? These cancers. So it could have grown over 4 years, or it could have grown. What's the least amount of time it could get to this point?
Well, it's different for everybody, but we do see some aggressive cancers that pop out kind of between mammograms, unfortunately.
Now, a woman with dense breasts, what does her breast look like on the interior? Is it mostly yellow, this fatty tissue here, like you mentioned? What does it look like if you have dense breasts on the inside?
So that is a great question. I do get that question all the time. And the density is actually the ratio of the milk glands to the fat. So density is not a clinical finding. You can't do a breast exam and say, oh, you have dense breasts. That's not how it works. It really is much more, it's based on the mammogram. It's a mammographic finding. So the radiologist will look at the mammogram and make a determination if there's more milk glands versus fat. And if there's more milk glands than fat, that woman has dense breasts. As a woman goes through life and goes through menopause generally, there's no need to lactate anymore, and so the density should start to go down because the milk glands start to atrophy a little bit. They never go away, but they atrophy, and then more fat comes in, and then eventually that woman won't have dense breasts anymore.
And what's the percentage of breast density that would require a woman to also have an ultrasound screening along with her mammogram?
Right. So we usually recommend that if it's over 50%, then there's a chance that we're missing something on the mammogram because the tissue is just too dense and we can't see through it. And so for those women who are over 50% dense, we'll recommend to have an adjunct screening like ultrasound or MRI if they're very high risk.
And so a mammogram is, you're going to see this whole picture in a mammogram versus, let's talk about MRI screenings and ultrasound. What are you actually seeing inside of the breast in those images?
So yeah, a mammogram is, just to remember, it's just an X-ray. They're very high quality, very high, looking very, very finely at the tissue, but it is just an X-ray. So what the mammograms are really looking for is the kind of the layout of the tissue to see if there's a difference from side to side, looking for asymmetries, looking for masses. And the other thing that mammograms are really good for is calcifications. Those are not going to be seen on ultrasound, and they're usually not seen on MRI unless there's something else going on. Ultrasounds are really good for detecting if there's small, solid, or cystic masses.
So it could be something
Yeah.
like these guys.
Exactly.
Yeah.
So you would definitely see on ultrasound something that's a solid or fluid-filled mass. On a mammogram, it would just look like a mass. It would just look like a white ball, and so we'd have to investigate that with ultrasound.
And so with an MRI, are you penetrating all the way down to the breast?
Yeah,
versus
so-
ultrasound and mammogram where it's more surface or
So no, mammograms and ultrasounds do look at the inside of the tissue, but they're static images.
Right.
The MRI is a dynamic study, so the patient will get an IV, and contrast will start going around through their system. And as they're going through the machine, the contrast will sort of leak out into spaces where there might be some blood vessels that are a little leaky, and cancers have blood vessels that are leaky. So anything that comes up as a bright spot on an MRI is something that we need to pay attention to. Doesn't mean it's a cancer, though, because lots of things can appear as bright spots. There are a lot of false positives, but it has a very high rate of diagnosing cancers if they're present. But it's an invasive procedure. It takes a long time. You have to get an IV. And so we really reserve that for people who are very high risk, like who have a mutation, a genetic mutation, or if you've been diagnosed with cancer and are being followed in that way.
I do want to talk about genetic testing. This is something that you're hearing more and more of because of family histories, women and men maybe who are at high risk. Genetic counseling or genetic testing is recommended.
Yeah, absolutely. So genetic testing is testing of a patient's DNA to see if they carry a DNA mutation that would predispose them to getting a breast cancer. And so the most common ones that we know about are BRCA1, BRCA2. There's obviously a very famous patient, Angelina Jolie, who was, kind of made her case public. She has BRCA2, and so she chose to have a bilateral mastectomy, a prophylactic mastectomy, before getting breast cancer because her mutation predisposes her to getting breast cancer anywhere from 40 to 60% lifetime risk. So she chose not to try to go down that road and said, I'm just going to remove my breast tissue to try and prevent that from happening. So genetic testing is indicated in certain situations, certainly for some women who have breast cancer who fit a certain criteria, and then other situations where there's a lot of family history. And so the real thing is to talk to your doctor to see if you fit those criteria and see if you can get your genetics tested that way.
What about women who do not have a family history but yet are developing breast cancer? I mean, we're seeing this more and more now. Is that, you can't really genetically test because there is no family history, or why would you?
Right. Yeah, unfortunately, 85% of the patients who we see have no family history of breast cancer. So we consider it sporadic in that situation. Some of those women who are young, they will fit the criteria for getting genetic testing, and we'll find that actually they do have a mutation that was inherited through their family. But a lot of times it is just sporadic, and so we recommend being very diligent about your self-exams, going to your doctor, getting your mammograms done, and being an advocate for yourself if you think that something is wrong.
I do want to touch upon immunotherapy. That's something that you hear about a lot, and it's using your body's own immune system to attack cancer cells and precision medicine. Those are kind of some buzzwords out there that many people may not know about. Can you just explain the difference between the two?
Yeah, so immunotherapy is using, as you said, sort of your body's techniques to fight cancer. And so there are other cancers that this is being used more for. Breast cancer is still kind of on the baby steps phase, if you will. One sort of smaller example that I can discuss is targeted antibody therapy. So there are forms of breast cancer that have a specific kind of growth factor that's present on the membranes of the cells. And so this has been recognized now, and we can treat these patients who have that with a targeted antibody treatment that targets that exact cell precisely. And because of that, because it's so targeted, we don't really have, there's not a lot of side effects from those kinds of treatments. And so what I think we're going to start to see more and more is this very targeted, very precision medicine, individualized medicine based on the patient's makeup and their own genetic analysis of their cancer and how we can target those specific mutations that are in their cancer.
I want to ask you a personal question. What made you decide to become a breast surgeon? Why become a breast surgeon?
Sure. So the bottom line is that I love being a woman who takes care of other women. I think we do everything. We, care for our families, our neighbors, our friends, our kids, and we kind of leave our health to the end. And I see that all the time. People coming in and saying, "Oh, I'm a year late for my mammogram," or I had to get the kids to school, and then I was gonna, get it, and then I forgot. So I get that, and I understand all of the pressures and the daily grind that women have to go through. And I love being a part of taking care of the people who are doing the most for everyone. Breast cancer is so treatable, and I think that really is the biggest message that I have for people. And so I think it's important to, I love having that as my go-to, career path, because I love being that woman who says, you know what, we're going to get you through this. You have a problem, we're going to fix the problem.
And you're making such a big difference. Dr. Wilson, thank you so much for joining us this morning. We appreciate it. And as always, thank you out there for watching. I'm Hartford Healthcare's Tina Verona. We're coming to you live from West Farms Mall this morning. Have a great day.